Assalamu alaikum. My case today, young age male, presented with attacks of melena with hemodynamic instability despite the good resuscitation. The OGD was done, but was negative, and urgent colonoscopy was not helpful, so they sent him for CT mesenteric angiography.
artery showing يعني cystic dilatation بالporta hepatis with avid contrast enhancement mainly بالarterial phase associated with mild ascites and pleural effusion, moderate ascites and pleural effusion. والله بعد ماشي دكتور زين. بالعكس. With extensive atherosclerosis changes بالarterial wall. اي نعم شوي بعد نمشي. بالعكس. عمي mainly connected to the hepatic artery, right hepatic artery. دكتور زيد ما عنده history of trauma أو شيء؟
هو عنده history of lab coli about 2
نعم.
months ago.
نعم. عمي هذا بالرايت هيباتيك ارتري فد ساكيولار دايليتيشن او انيوريزمال دايليتيشن.
تقدر تأشره بالماركر مالتك؟
انا من يمست هذا؟
ايه اكو ماركر، تروح على الجهه اليسرى شو اسمه لا مو هذا، مو هاي هاي اكو قلم يصير بالليفت لور. منو اشره زيد؟
نعم
نعم استاذ.
ايه لا انا رديت محمد ياشره.
والله عمي هذا هو الدايليتيشن بس ما اعرف من
يلا اوكي بعدين اكو سكيولار دايليتيشن. اي
سكيولار
هالشكل.
دايليتيشن. نعم.
ريليتد
عمي
للرايت، ريليتد
بالرايت هيباتيك
للرايت.
ارتري. نعم مينلي بالرايت هيباتيك ارتري.
اوكي.
هو عمي هيمودايناميكالي انستيبل، فممكن يكون هذا الدايليتيشن هو ممكن يكون يعني انيوريزم وذ رابتشر، يعني رابتشر انيوريزم.
بل
اي رايت هيباتيك ارتري انيوريزم وذ رابتشر.
اوكي. اذا هذا يعني خلينا نقول كومبليكيشن واحد من خلينا نقول النوت انفريكوينت كومبليكيشن بوست لاب كولي هو انيوريزم اوف ذا هيباتيك ارتري. شو يسوي له هذا؟
والله عمي هذا المفروض يعني urgent treatment، لان هو البيشنت انستيبل هيمودايناميكال انستيبل، فممكن ممكن يعني انترفنشن نسوي له، يعني ستنت او ريبير او هيك شيء يعني.
لا بالانيوريزم شو يستخدمون ستنت؟ الستنت وين يستخدمون؟
الستنت ممكن عمي بالسيدو انيوريزم.
لا الستنتات عاده
او
وين
ناروينج، او
يستخدمونها؟
اذا عندنا ناروينج او
اذا عندنا ناروينج مو صحيح؟
نعم.
او
نعم
اوكلوجين او
او
هذه
اوكلوجن.
يستخدمون الستنت. بس
نعم.
الانيوريزم شو يستخدمونه؟
والله عمي ممكن نستخدم له امبلايزيشن. امبلايزيشن. نعم.
امبولايزيشن.
نعم.
شنو الواي اوف امبولايزيشن يعني شو يستخدمون؟
يعني هو عمي الانترفنشن يعني نطب للارتري
الانترفنشن يعني شو يخلون شلون يسوي لها امبولايزيشن للانيوريزم؟
كويل عمي كويل
كويل
امبولايزيشن.
يخلونها كويلز
نعم.
شو اسمه يصير ثرامبس وتنسد. اوكي.
لان عندنا
شكرا
هواي كولاترال احنا بالليفر فيعني نسوي له امبولايزيشن افضل.
شكرا دكتور محمد.
عفوا.
احكي لنا على الكيس زيد.
نعم أستاذ، هو young age male يعني عنده history of lab coli about 2 months ago وهم presented with the GIT bleeding يعني upper GIT bleeding with hemodynamic instability. As we can see by the native CT scan, there is surgical eclipse here in the gallbladder bed. Okay, with an LV found here cystic lesion seen by native CT scan.
صحيح.
كان
امسحن ذني
بالارتيريال
محمد خضير، امسحن من يمك ديليت ذني اذا انت سويت هاي شو اسمه، بس روح على نفس القلم وافتحه وقول له ديليت. ايه يلا عشت ايدك، تفضل زين.
نعم أستاذ. So by arterial phase angiography, we can see that this cystic dilatation showing arterial enhancement similar to the arteries, and it's origin from the right hepatic artery, so it's suggesting an aneurysm. بس هنا نلاحظ انه هذا الارتري arising from the superior mesenteric artery. This is an accessory right hepatic artery causing an aneurysm. يعني probably they don't know about it during surgery فصار اكو injury during removal بسبب ان هذا الانيوريزم. طيب بالنسبه للريليشن للبرزنتيشن مع الكيس، يعني احنا هنا اذا ندقق بالنسبه للنيتف سي تي سكان، يعني ممكن نلاحظ ممكن هنا اكو ايكوجينيك بلاد انسايد البلياري تري. يعني هي بالنسبه للكومن بايل ده
يقول لك الصورة سوداء هاي طالعة عندنا، مدى يبين كل شيء.
اي استاذ، يعني حقيقه هنا اكو فد ايكوجينيك يعني ستراكشر كانما هو هايبر اتنويتنج بلاد موجود داخل البايل ده، فانه suggesting arteriobiliary fistula.
باين.
هنا بال 3 دي سكان راح نشوف انه هو الاوريجن مال الارتري. هنا نطالع من السوبيريور ميزنتريك ارتري as an accessory right hepatic artery، والرايت hepatic موجود، هذا هو الانيوريزم.
اذا هذا فاريشن يعني الهيباتيك ارتري رايزنج from the superior mesenteric، مو صحيح؟
نعم. هذا الانجيو مال الكيس.
ما اشتغل عندنا الانجيو، ما مبين بس الكاثيتر.
اي نعم ثواني. طبعا هذا بداية بالسيلياك ترانك بنشوف يعني البرانشات اللي هي السبلينيك والليبكاستريك والكومن هيباتيك ارتريز، وما واضح من عندها الانيوريزم. هنا بالسوبيريور ميزنتريك ارتري بالنسبة للليفت سايد برانشز، هنا عمين بالنسبة للكومن هيباتيك ارتري يعني بالسوبيريور ميزنتريك بالرايت سايد هذا الاكسسوري رايت هيباتيك ارتري والسيدو انيوريزم. هذا عمين successful treatment post embolization.
Very good. اوكي. عشان بدك مسوي توك حتى نروح على التوك.
نعم. So hepatic artery pseudoaneurism. Starting generally speaking about the true and the false aneurysm. The false aneurysm or aneurysm in general are outpouching or dilatation in the wall of the arteries, which are bounded by the tunica adventitia. The true
ارجع.
So the true aneurysm contain all the three layers of the vessel, the tunica antenna, tunica media, and tunica adventitia, and it can be either circular or fusiform aneurysm, while the pseudoaneurism is by definition, it is a contained leak by the tunica adventitia, as we can see by this image. Okay. Regarding etiology of false aneurysm, هو most common cause is traumatic, whether dissection or laceration, يمكن تكون iatrogenic. Most commonly نشوفها بالpractice بالarterial capitalization, spontaneous dissection, fibromuscular dysplasia, mycotic aneurysm, myocardial infarction بالنسبة لل left ventricular aneurysm, regional inflammatory process, pancreatitis can cause gastroduodenal or artery aneurysm, vessel injury or erosion due to a tumor, vasculitis syndromes, or penetrating atherosclerotic ulcers. Regarding the true aneurysm, it is bounded by all the three vessel layers, as I said, and the wall may be attenuated, and the risk of rupture in the true aneurysm is proportional to the size of the aneurysm. The causes of the true aneurysm are different. It can be congenital or atherosclerosis, which is the most common cause of the true aneurysm, hypertension, vasculitis, hereditary connective tissue diseases, and the fibromuscular dysplasia, syphilis, and the myocardial infarction. مقارنة بسيطة بين الترو and the false aneurysm. The true aneurysm contain all the three vessel layer, while the false aneurysm was a contained leak by a tunica adventitia. Most common cause by the true is atherosclerosis, by false aneurysm it's traumatic. The true aneurysm has low risk of rupture, while the pseudoaneurysm very high risk of rupture. So all the pseudoaneurysm should be treated. So the pseudoaneurysm can involve any arterial segment or even a cardiac chamber. بعض examples can يكون aortic pseudoaneurysm, femoral artery pseudoaneurysm هو commonly هذا بعد cardiac catheterization through the femoral approach, carotid artery pseudoaneurysm or visceral arterial pseudoaneurysm اللي هذا my main topic. So I can cystic artery or renal, splenic, hepatic arteries, peripheral lymph pseudoaneurysm or left ventricular pseudoaneurysm, brachiocephalic with pulmonary artery pseudoaneurysm اللي يصير بالبهجة. This is a case of a kidney transplant patient showing a renal artery pseudoaneurysm. This is a case post cardiac catheterization showing radial artery pseudoaneurysm. Another case here post cardiac catheterization showing an aneurysm with common femoral artery due to aggressive catheterization. This is a left ventricular aneurysm seen by chest X-ray. Regarding the cardiac aneurysm, the true and the false aneurysm, the causes are mainly coronary artery diseases. Location by true aneurysm, it will be anterior wall and apex pseudoaneurysm with posterior lateral wall. The risk of rupture always is high with pseudoaneurysm and therefore they should be treated. Regarding the vessel wall layers, true aneurysm is just thin out myocardium, while the pseudoaneurysm is just pericardium and the fibrous tissue, no myocardium. The true aneurysm have a wide neck اللي هو أكثر من 20% of the maximum sac diameter. The pseudoaneurysm they will be narrow neck. The management for the true it will be medical mostly, while pseudoaneurysm is surgical management. With ventricular dysfunction, the true هيكون significant dysfunction and akinesia. The pseudoaneurysm is usually normal. Have another picture showing a common carotid artery pseudoaneurysm by angiography and by ultrasound. So the radiographic feature for a pseudoaneurysm, by ultrasound we can see turbulent forward and backward flow, as we can see in this image, the yin-yang sign or the Pepsi-Cola sign. By CT scan we will have a hypoattenuating non-contrast enhancing with hypoattenuating non-contrast with hyperattenuating contrast enhancing material adjacent to arterial wall, usually with a communication. Regarding the treatment and prognosis for pseudoaneurysms in general, the risk of rupture is higher than the true aneurysm, and therefore all false aneurysm they require treatment. This is the appearance by different imaging modality, by duplex ultrasound, by CT angio, 3D volume rendering, and the catheter-based angiograph. Regarding the visceral arterial aneurysm, here involving the splanchnic arteries usually, and they can be true aneurysm or a pseudoaneurysm. The incidence of 0.01% to 2% on autopsy and angiographic studies, and 50% of these are involving the splenic artery. Regarding the clinical presentation, they are mostly asymptomatic and can be discovered incidentally. Less frequently, they present with abdominal pain and a pulsatile mass. 25% can be complicated by rupture, and this patient usually present with acute abdominal pain and bleeding with a high morbidity and mortality. It causes يمكن تكون هي degenerative deficiency of the arterial wall with the loss of the elastic fibers and reduce the smooth muscle. Regarding different causes, pancreatitis, for example, can cause the destruction of the arterial wall, resulting in pseudoaneurism of this related visceral artery, or segmental arterial medullosis is also a recognized cause. Examples of the visceral arterial aneurysm, they can be multifocal in 1/3 of cases. Splenic artery is the most commonly involved 70%, and the hepatic artery is the second most common visceral arterial aneurysm, and other rare entities, superior mesenteric, gastroduodenal, celiac, and the inferior mesenteric. Here are examples of this is a splenic artery aneurysm. This is a case of a common hepatic artery aneurysm, and this is a case of an inferior mesenteric artery aneurysm. Again, this is by CT angio. This is a hepatic artery aneurysm. This is a case of a gastroduodenal artery pseudoaneurism, which is a branch of the splenic artery, and this is the same case showing it by capital angiograph. Regarding the treatment and the prognosis, follow-up and the treatment recommendation, they are different according to the different type of the visceral arterial aneurysm. In general, all pseudoaneurysm should be treated, and the true aneurysm, when they are more than 2 cm, they should be treated. The follow-up recommendation for visceral artery aneurysm is not recommended. For example, patient with the pancreaticoduodenal system post-operative procedure are at a high risk of rupture than any other visceral artery aneurysm. So if you suspect a pseudoaneurysm, put the patient on a short follow-up interval because of high risk of rupture. Regarding the hepatic artery aneurysm specifically, which is the representing 1% of all the arterial aneurysm and 20% of all the visceral aneurysms, and it is the second most common cause of splenic system involved after the splenic artery aneurysm. It can be intrahepatic or extrahepatic part of the hepatic artery. Treatment and prognosis, rupture of hepatic artery aneurysm can be seen in more than 80% of patients, with a mortality rate reaching 40% with surgical management. So early treatment is preferred over follow-up, and the treatment of choice is embolization with intrahepatic form, as it will not impair the liver vasculature because of the collateral blood flow. We have dual circulation from the portal and the splenic, from the portal and the hepatic artery. Endovascular stenting sometimes may be the best alternative in aneurysm with extrahepatic portion of the hepatic artery. Secondary management option include prosthetic graft reconstruction, excision, and surgical ligation. This is a diagram showing the management of different type of visceral arterial aneurysm. Worth mentioning is splenic artery. All pseudoaneurysm should be treated. True aneurysm when size more than 3 cm, and all sizes in women of childbearing age. When hepatic artery should be treated when it is symptomatic, its size more than 2 cm, and the growth more than 0.5 centimeter per year. Short notes regarding the hemophilia. The hemophilia is the process of the blood in the biliary tree. By clinical representation, we have the classical Quincke triad seen with hemophilia in a context of hepatic artery aneurysm. They will present with upper GIT bleeding and jaundice and abdominal pain. Regarding the causes, the most common cause is iatrogenic, traumatic iatrogenic by surgical or percutaneous procedure. It could be post-traumatic pseudoaneurysm from a central liver trauma, usually presenting 2 to 4 weeks after initial injury. It could be a vascular malformation like hepatic artery aneurysm or AV malformation, and they usually cause massive hemophilia. Sometimes malignancy to cause destruction and weakening of arterial wall, or most commonly it is hepatocellular carcinoma and the gallbladder metastasis second, and abscess formation or GIT bleeding due to gallstone can cause hemophilia. This is the different interventional modalities which can cause a hemophilia as a consequence of hepatic artery aneurysm or whatever the cause. Percutaneous or transjugular liver biopsy, TIPS, a spontaneous thermal ablation, or can be surgical, hepatic resection, hepatic transplant, procystectomy, pancreatic surgery, or endoscopic by ARCP or biliary stent placement. Well, most common causes are iatrogenic. Regarding radiology, you will find the radiological feature by ultrasound. This is the first investigation. We reveal ecogenic material, usually in the bile duct and dilated gallbladder. You can see ecogenic blood inside the gallbladder. And by CT scan, as in this patient, we can see a high attenuation clot sometimes within the bile duct. So the challenges in the diagnosis of management of hemophilia by different imaging modality, we need a high index of suspicion to diagnose it. We will see layering of the blood in the common bile duct and ecogenic intraluminal blood in the dilated CVD. Here by angio, we will see active extravasation from the distal arterial branch, and here by ARCP, removal of the coagulated blood from the CVD. This is a case also of an arteriobiliary fistula after an orthotopic liver transplantation in a 59-year-old woman presented 5 days after a transjugular liver biopsy with an acute abdominal pain and hematochezia. So by axial non-contrast CT scan showing a hyperattenuating blood inside the bile ducts. Again, this is a coronal CT scan non-contrast enhancing showing under echogenic blood inside the bile ducts. This is a selective hepatic artery angiography showing the leakage of the blood to the bile ducts, and these are the branches of the hepatic artery. So this is a bile duct. This is confirming the presence of an arteriobiliary fistula. And later on, after embolization, we can see the successful treatment after embolization. And thank you.